Why do the same problem behave so differently in the right side to the left side? Why tricuspid atresia goes almost always with ventricular septal defect, and mitral atresia almost never goes with ventricular septal defect? Why in the left side is so uncommon to see ventricular coronary connections, and on the right side they are fairly common? Why in the left ventricle we have endocardial fibrinoelastosis, in the right side is very rare? So very many questions.
No, I think, you know, what you think I am God, I know this answer. But at the end of the day, it's probably embryology.
Yeah.
Why we have 20 times more double outlet right than double outlet left ventricle? So because of the rotation of the heart could be so. Also, the structure of the right ventricle is more spongious, leading to a possibility of having communications. And I can also imagine that some of the anomalies developed and die at 8 weeks as a miscarriage. If there is something quite severe between the left ventricle and coronary system and the aorta, you will end up of having hydrops and death. So, but so the mitral atresia is a good question, but probably the one you are pointing at is the whole left outflow and inflow is the package of mitral and aortic atresia.
I think also that it's very important that the left and right ventricles, the anatomy itself, it's very different. Yes, so now in fetal life, well, we see the two ventricles, okay. But actually the anatomy is super different, no? And the left ventricle, it's more like a tube, and then the other one is more triangular. Then the amount of trabeculations of the right ventricle is very different. And then also how the anatomy is disposed, the right ventricle goes to the pulmonary artery and branches, no? Very quickly. And in postnatal life, the right ventricle tolerates very badly the pressure because it's very short, like the pulmonary artery is very short, where the left ventricle, the anatomy, the distribution of fibers, the longitudinal fibers, and are very different. So they might look, but the anatomy inside, it's very different, and maybe that's why they behave so differently. I think Julien wants to add.
I think it's more to do, can you hear me? It's more to do with the type of hypoplastic left heart, because you do have ventricular. Is it on?
Yeah, we hear you. Bring it more.
You know, the typical hypoplastic left heart is mitral atresia and aortic atresia with a non-existent left ventricle. The typical pulmonary atresia, intact septum, is usually has some flow across the tricuspid valve and nothing going out. So if you have mitral stenosis and aortic atresia, you are at risk of ventricular arterial connection, the same as on the right side, and they can influence the ventricular function on the right side. They can be still. I will show tomorrow a case of hypoplastic left heart with huge coronary connections. You don't see them in the typical mitral atresia and aortic atresia because the reason for the connection, as Rabi said, is you have flow going into the chamber, so you have to have stenosis of the mitral or tricuspid valve, but no way out. So the only way out is through the connections, and that's not the typical case of hypoplastic left heart.
Right, thanks. But it's also known that the tricuspid valve in itself contributes mainly to the formation of the ventricular septum. That's why when there is no valve, there is no tricuspid valve, there is a defect on the septum, because the contribution of the tricuspid valve to the formation of the ventricular septum fails, and that's why there is a hole in the ventricular septum.
That makes sense.
It could be also that the fact that the left side is, for the blood coming in, more optional. So if it does not develop, it can still go to the right side. While opposite is not the case, because it will anyway end up on the right side. And so if there's a big problem there, you will see it and it will interact. But you can have a closed foraminal valve in the left side, maybe even ignored, because only the lung veins will, at the end, may be of importance. You can have the whole development on the right side of the heart. But one day we'll know. I have a question for Reem. When you were speaking, I was wondering, giving one pitfall after the other, how much of these pitfalls are we going to solve with artificial intelligence?
Well, artificial intelligence is going to see what you give it at the moment. And so I think it's not going to be able, if I don't give it a good image, how is it going to get anything out, right? And that's why I also believe that if we were to standardize how we sweep through, this will really enhance the efficiency of artificial intelligence. Right now, we have software that is available. We connect to our machines, and you can be scanning any which way. Some of the software is embedded already. And it will tell you it's a good image, you can get better, or so on. But if we want to enhance, I think, artificial intelligence, we should start abdominal circumference plane and sweep up very slowly towards the fetal head, because then it's going to be able to do better. And then if we concentrate on optimizing that sweep, I think the output from artificial intelligence will be better versus haphazard techniques, not haphazard, but it's as we are scanning and moving around to try and be more purposeful in our acquisition.
But also, the presets of the machine are still operator dependent.
Yes.
And the machine can, if you have some good AI, it may adjust for you considering the different scanning conditions, may recognize this is a bad thing. It will start doing on its own. Like in a car, the car today knows that it's raining.
Yes.
You don't need to think, oh, now, is it rain? It will start. I don't want now to have it start. So the machine can adjust, and if there is a region behind the heart, you think it's okay, it will warn you, no, I don't like it. And then you have either you say, shut up, I'm sure that you will miss, or you will have to do it until you get the response. I'm sure that some of them can be supported, but we still need some skill.
And I
Give
think
me a
because
hope.
we stop and think, are we going to be obsolete in the next 5 years? No, because acquisition and optimization are still so critical. What AI would be fabulous with is if it can control my machine settings, no matter what my level is, to realize this is high BMI, there is shadowing here, let me try to take over and optimize this image. And I know we have auto optimization on some of the machines, but it's got a way to go. So I think that's the first step. And then, yes, we'll see how it goes.
Yeah, but I think that in optimization that would be perfect. I think it can help also to highlight, such as on a first screening, no? If it says, okay, maybe I don't like, but I believe that at least at this point, that our opinion, no, because at the end, the machine can say, okay, this I don't like it, or focus on this, but at the end, you will need an expert to go there and say, yeah, that's it, because, well, I don't think we can just, because, and then there is all the issue of our responsibility, no? So at the end, the doctor
but if I
needs to
show
have
it
the
a VSD, if that's all I give it, is the VSD with the override, it's going to read it as a VSD and override because I am oblique and I don't have the right color settings. And it would be worthwhile to test the AI that's out there now, with and without optimization, and does it change its reading if one is optimized and one is not?
Okay, let me, for the VSD in general, if you have a true VSD, the region of the VSD is covered by endocardium. So, and the image may not show this, but the system, inside the system, they may have a lot of information they could not display on the screen. And this system may recognize some echogenesis. So sometimes I compare AI with my daily work like Word. So 15 years ago, I wrote a text in Word, and it told me Chawi does not exist with red lines and give me some suggestions. And I said, learn or accept. Some years later, it's correcting automatically. So it wrote me Chawi, also the automatic correction. Today, I say, please write me a text of 5 sentences. Write a text of before I start sitting, I say one word, it writes the text. So this is why today we think only in the dimension what we can solve. But I'm sure if we are aware, and this is why I'm really highly appreciating your talk, we're aware where are the pitfalls, where are the mistakes, we can challenge and ask the people doing AI, please, this is our problem. Our problem is not discovering a coronary fistula. Our problem is solving these issues, which is the whole world, the main problem, safety of examination, in difficult scanning conditions, and so on and so forth. And they can work on this field instead of saying, I'm afraid to be obsolete. will be anyway obsolete one day, but this is not the issue, not our
No,
lifetime.
no,
actually.
of course.
But I think we should give it a chance.
Yeah.
This is what I'm...
Absolutely.
We have a question, Alberto, with regard to the small left ventricle and how to manage the small left ventricle caused by a foramen ovale aneurysm, and if you would consider doing a hyperoxygenation test in that setting.
I didn't understand you. How to manage what?
So it's a small left ventricle in the setting of a foramen ovale aneurysm, so a ballooning of the foramen ovale into the left atrium, causing a small, the concept of it causing a small left ventricle, and a differential diagnosis for a hypoplastic left ventricle.
Yes, this is true. This is a very common clinical scenario when you have a ballooning of the septum primum, and this causes even most commonly in the last weeks of pregnancy, a cardiac asymmetry with the right side larger than the left side. This is a cause of false positive cases of coarctation of the aorta. And the same happens with persistent left superior vena cava. This is also a source of false positive cases. You have to measure mainly the cardiac isthmus to be sure that the cardiac isthmus has a value usually greater than -2, so theta value greater than -2. So the cardiac isthmus is the most powerful parameter to make this distinction between a true coarctation or a false positive case of coarctation. When you see a septum primum ballooning and including the mitral flow, no?
I mean, I guess we'll get to talk about this tomorrow, but and tell me if you agree or disagree with me, or Julene, if your input as well. But I think the setting of a redundant foramen ovale and that setting of a small left ventricle, and even in the setting of a bilateral superior vena cava that supposedly causes this mechanical obstruction to the left side, and that association with coarctation, I really feel these are normal babies, the vast majority of these. And when they may look like they're sort of an evolving coarctation, in fact, we're creating an awful lot of anxiety for these patients. And I don't honestly believe that it does cause a mechanical inflow from left to right side. For the vast majority of those where we see that foramen ovale aneurysm, small left ventricle, they don't go on to develop coarc. And similarly for bilateral SVC, it's put out there as being a very strong marker for coarc, and everybody's highly alerted, and the patients are cancelled and they're transferred from country Australia to Melbourne for delivery, and afterwards, you know, the duct closes, the aorta opens, and there's no coarctation.
Yeah.
I don't know what everybody's thoughts are on that. Ravi?
It's in my talk on septal defects and in my talk on coarctation the same, because everyone sees a bulging of the foramen that, it's going to be to an EST. So you'll listen, I'll show 2 slides, but I will get also on this point tomorrow also. I'm speaking on coarctation, it's also part of the talk. Because on the false positive in late gestation. So this.
And most of these babies have a normal scan, absolutely normal in the mid pregnancy.
Yeah.
Well, this is a late finding, usually a late finding in the ballooning of the septum primum. So, and one of the most powerful markers of coarctation is the earliness of the cardiac asymmetry. You know, those that appears in the second trimester pregnancy usually have coarctation of aorta, while those appearing only in the third trimester of pregnancy usually are false positive cases.
So I think the answer to the speaker online who put forward that question, I'm sorry I can't remember if your name was there, we will answer that question. I'll address it in further tomorrow. And I think also, Rabbi, I'm talking about persistent left SVC, so I'm hoping between us we will explore that question a little bit more. Are there any other questions at all from the audience?
Yeah, the question also mentioned it about hyperoxygenation to test.
Yeah.
Does anyone use that?
Yeah, I mean, the only scenario I know of hyperoxygenation is in the setting of predicting of ballooning of a foramen ovale in the setting of transposed great arteries to try to risk assess those who need to be transferred for balloon atrial septostomy. And the idea is you hyperoxygenate and increase the venous return to the left side of heart, and that would exaggerate a foramen ovale aneurysm. But I've never actually heard it in the setting of diagnostic value in an isolated foramen ovale setting in which the question was asked. Julene, if there's a microphone there for Julene. Julene, if you can...
So we are doing hyperoxygenation, but in a research setting.
For TGA.
So,
Yeah. But
Okay.
yeah.
you will to comment on this? Can I please, before you start, because
sorry.
I'm sure many people do not know what we are speaking about. So the issue is that lung vessels become oxygen sensitive in legislation. If you give the mother oxygen, it leads to a dilation of the lung vessels and higher flow from pulmonary artery, ductus arteriosus, but in the peripheral arteries into the lung, bringing more blood back into the left ventricle. You see higher flow in the pulmonary veins and higher flow into the left atrium. And then this can be used, some are trying to use it for therapy, some are used for testing. So this is what it's about now. It's called maternal hyperoxygenation. So please, Giulini.
I first heard about it from Jack Rychick many years ago in one of the ISWAG meetings, and he presented it exactly for the distinction between coarctation or not, because it simulates birth by increasing pulmonary blood flow. So then you increase the dimensions of the left ventricle. So I don't think anyone is using it as currently, but I think the idea started for that, and now people are trying to use for transposition, as you mentioned. We don't use it, at least I don't, but some people in our newly merged unit are using it for transposition.
Actually, the hyperoxygenation, to my knowledge, was developed by Thomas Cole and the people in Bonn. And it works in the term of changing flow. So I can show you tomorrow, after that, one slide with, and so it works really, you see higher flow. But the question is it changing natural history? Because you cannot do hyperoxygenation at 22 weeks because the lung vessels are not dilated with oxygen. If you give it at 30 weeks, you may have the disadvantage of having the retrolentar dysplasia of the retina. So this is why they can start using it 34 weeks because it will not cause harm. But are you able, the question I'm asking myself and everyone, to change the histology of the Arctic isthmus? I
see, Rabbi. So there are two scenarios. One is using hyperoxygenation in the setting of a diagnostic test. The other is in the setting of a therapeutic.
This is new.
Yeah.
Using as diagnostic. But at the beginning, he was using it mainly, or still using it mainly, to change the natural history, saying some fetuses, when they show coarctation, we give them oxygen and they don't need surgery. But I say, come on, if you have 5% at the end true positives in late detection, so how can you convince me? And he told me it is not working with left superior vena cava. I said, okay, so even this group. And then later on, some intelligent people discovered we can use it as a test. For the hemorrhagic hernia, are the vessels reacting? Because in some cases you have an hypertrophy of the veins, like in restrictive foramen ovale and so on. Use it as a test. This is new approach, and this is what Jack Rychick is suggesting. So question, go ahead, please.
I just wondered what effect that would have on the placenta, maternal hyperoxygenation. Because I think some of the work that was done physiologically by Burton, Eric Junot, and so on, I think this has been tried. But for different reasons, not for cardiac reasons, but to try and improve fetal growth and things like that. And I suspect somewhere my mind says it might actually have a harmful effect.
Yeah, I have heard about maternal hyperoxygenation to check how it affects the placental perfusion, but as far as I know, it's all, again, as a diagnostic tool, and it's just 10 minutes of hyperoxygenation to see, and then you can measure the perfusion of the placenta and to see how it interacts, or how it's increased or not. But as far as I know, it's as a diagnostic tool, short exposure. Yeah. So
we have 15 seconds left of Q&A, and maybe just a very quick one, Rabbi. You spoke about the first semester, how pulmonary atresia with intact ventricular septum and tricuspid atresia with VSD, how these had a very, very high detection rate. And it was very interesting to read, Rabbi, about your slide where you spoke about the pathogenesis of coronary artery collaterals, that maybe it's actually that malformation in the very beginning that actually gives rise to the setting of pulmonary atresia with intact ventricular septum. But the challenges, I guess, are in the first semester in seeing those coronary artery collaterals. I mean, do you reckon that we can see these in the first trimester? Because ultimately cancelling that patient who you saw back in 1998, who you cancelled favourably, Rabbi, you probably were in a situation where you saw there were no coronary artery collaterals and she was in the good prognostic group.
Sorry, I was focusing on checking. Can you show us the slide?
That's okay. Well, what we might do is
I'm not the pro. I want only that. So this is an example. This is a patient with coarctation. I saw, and she went to Dr. Cole to get this treatment. She came back with the luggage. So she came to my unit with the luggage. Said, "What is the luggage?" A bottle of oxygen. So she opened. She had a bottle of oxygen like on the ICU. She said, "Scan me before and scan me after." So I scanned her before. This is the pulmonary veins. And she went to the room. She inhaled some 20 minutes long. She came back, and this is what I saw. It works. I told him that, Thomas, I believe you. It works in changing this, but I don't believe it's going to change natural history. Confirm, because you need true cases of true coarctation, and we still have difficulties in getting a true diagnosis prenatal to say, I'm sure it's going to run into coarctation. And the cardiologist says, guys, you cannot change. We have histology of cells on this shelf. How can you remove this within 3 weeks of treatment? So, but this here, you see the changes in the flow before and after O2. And the idea of getting testing via oxygen is elegant. Because you say, we have now, let's say, diaphragmatic hernia, we have some flow, we give oxygen, it's not reacting, it's not opening, it's not changing. Yep. It's unlikely we may need ECMO, or it's reacting, so we have a chance that it does not have pulmonary hypertension of the newborn. So this could be an interesting approach. So give it a chance, but since no one of us is doing it on a routine basis, let's give questions which are quite practical for the audience. But this is here how it works, before and after.
And the other thing, on all the published data related to this, the time frame in which you take the oxygen is for 20 minutes, I think is the period of time. You basically, high concentration oxygen for 20 minutes, and then you come back and do your Doppler studies. Anyway, we had a great Q&A, and we might stick according to the schedule, a break, and then come back again after the next section. Thank you.